This is ECG Q&A number 2. The question is, a 65-year-old woman with diabetes who had severe heart failure for last 2 years was reported to casualty with increasing breathlessness and ankle swelling despite having been treated with angiotensin converting enzyme inhibitors and diuretics. This is the ECG of the patient, so let's see what we can find out. So if we analyze the ECG, there is severe bradycardia. It's around 36 to 40 beats per minute and the rhythm appears irregular, and there are very small voltage P wave can be seen in V2 and V1. Okay, and there is a broad QRS complex with an atypical left bundle branch block morphology. There is symmetrical peaking, or we can say tenting of the T wave in V2 to V5 leads. So for diagnosis purpose, we have 4 things here. Number 1 is bradycardia. Number 2 is flattening and loss of P wave. Number 3 is QRS broadening. And number 4 is tented or peaking of T wave, which leads to our diagnosis as a hyperkalaemia. See, golden point for potassium imbalance ECG is the push and pull effect. In hypokalaemia, there is a pushing effect, means the T wave is pushed down, so the resultant T wave will be flattening or inversion of T wave. There is ST depression and there will be a prominent U wave. Okay, you see this diagram, there is pushing of T wave and there is uprising of U wave, and opposite of that there is a pulling effect in hyperkalaemia. It means the T wave is pulled upward, which creates tall and tented T wave. The stretching of the T wave will lead to stretch the remainder of the ECG, which causing the P wave flattening or disappearance of the P wave. And next is PR prolongation and the QRS widening. This is our hyperkalaemia ECG. Look, the ECG manifestation in hyperkalaemia progress from tall and peaked T wave, means 5.5 to 6.5 millimole. Okay, to the loss of P wave, it will be at 6.5 to 7.5 millimole, and to the widened QRS complex, it will be at 7 to 8 millimole, and ultimately to the sine wave pattern, there will be more than 8 millimole of potassium. However, these changes are notoriously insensitive, particularly in patients with chronic kidney disease or ESRD. So for the treatment purpose, number 1, we are using immediate antagonism of the cardiac effect of hyperkalaemia, means we are using calcium gluconate. Number 2 is rapid reduction in plasma potassium concentration by redistribution into cells, which we can use insulin with neutralizing effect, and the other one is removal of potassium.